Live.
Good morning, ladies and gentlemen. I'm Dr. Jaime Estrada. I'm President of Texas Doctors for Social Responsibility and co-chair of our third Health Policy Forum. I want to welcome you to the third session entitled Social Determinants of Health Care, the Vulnerable and Uninsured. I thank you for joining us. I also want to thank Health Collaborative and the National Hispanic American Association for partnering with us, our session chairs, panelists, our advisory board, our sponsors, in particular, the Methodist Healthcare Ministries for their support. Now, I'd like to introduce Dr. Adolfo Urbi, chair of the conference, chair of the session. Dr. Urbi is a compassionate family practice physician, epidemiologist, and community organizer. He has always been an activist for access to healthcare, has provided health for the poor and uninsured community and in communities colonial in both sides of the border. He's the founder of Bridging Quote and past president of Texas Doctors for Social Responsibility. Dr. Urbi.
Thank you so much, Dr. Estrada, for that kind introduction. It's my pleasure to serve as chair of this particular session. We have a very distinguished panel of speakers. I'll introduce them briefly now and more detailed as each speaker presents their material. We have Dr. Carlos Roberto Jaén. He's chair of the Department of Family Community Medicine, UT Health. We're happy to also have Dr. Linda G. Solis, assistant professor of the URW School of Osteopathic Medicine. Also, we welcome this morning Dr. Sandra Guerra, interim deputy director for the San Antonio Metropolitan District, and Dr. Rogelio Sainz, professor of demography here at our own UT San Antonio. I'd like to introduce in more detail our first speaker and moderator, Dr. Carlos Jaén. Dr. Jaén is currently professor and chair of the Dr. James Hawley Distinguished Chair, Department of Family Community Medicine, UT Health, San Antonio. He's also professor of the Department of Population Health Sciences and adjunct professor of public health at the UT School of Public Health, San Antonio campus. We'll go ahead and have Dr. Jaén begin his presentation. Thank you very much.
Good morning. It is a great pleasure and a privilege to present to you this morning. I am very thankful for the invitation.
Okay.
I would like to, in today's presentation, I would like to focus
Dr. Jaén, please hold on for just a minute. We're having audio problems. I'm going to refresh the screen here. Okay, go ahead. Go ahead, Dr. Jaén.
this morning. I would like to focus in the larger picture of our health disparities in our communities that are still apparent in the context of the current pandemic, and they're affecting so disproportionately, particularly Latinos and African Americans in the community and nationwide. So I would like to begin by defining health disparities and social determinants of health, and then present a specific case for systemic racism in San Antonio that is producing increased morbidity and premature death. Describe the extent of the probable lack of health insurance among Texans, and then identify concrete steps that clinicians could take to address health disparities. So health disparities is not a difference in health outcome, but it's a difference in health outcome that is systematic, avoidable, and unjust. So It is important to keep in mind that a health disparity is not just related to personal responsibility, and it's just not related to access to health care or health insurance. It's really a wicked problem in the sense that it eludes simple solutions, involves structural changes, and it has a large economic burden, and it's interconnected with many problems in our communities. Health disparities are not just a healthcare issue, they are social and a full community problem. One of the related concepts that is important to keep in mind as we're talking about health disparities is the notion of social determinants of health. So what are social determinants of health? They are conditions under which people are born, grow, live, work, age, and include factors such as socioeconomic status, education, employment, social support networks, and neighborhood characteristics. These have a greater impact on population health than factors like biology, behavior, and healthcare. So, social determinants of health, especially poverty, structural racism, discrimination, are the primary care drivers of health inequities. You can see in this diagram the range of factors that affect health are, wide, are very important in the context of all the areas that are involved, from living in working conditions to unemployment to housing, and also the general socioeconomic, cultural, and environmental conditions. So it's important to keep in mind that the social determinants of health, the health inequities um, that we experience in this country are not unique to us. They're really worldwide, and they
Dr. Hyan,
yes.
I'm so sorry. The audience is still having sound problems, and I don't know what's causing it. So we need to try to troubleshoot this because apparently it's the unintelligible. Okay, try to reset one more thing. Go ahead and start again. Start at the beginning of your slides.
Let me stop sharing.
Go back to the beginning of your slides and start over, and let's see what people tell us.
I can hear you.
Dr. Hyan, start your slides over again. Go back to the beginning of your presentation, and let's see if this improves it.
But now, can you hear me?
Yes, I can hear you.
Go ahead, Dr. Hyan. Start presenting.
How can we address health disparities in our communities? It seems to be fairly straightforward if you think about how many people talk about health disparities. Even in the recent Bear County Medical Society, full body quality, let's make it equal. Things will be easily fixed. Well, the reality is that health disparities are a significant problem that we need to address in our communities, and we need to make sure that we understand. In order to do that, we need to have clarity about what health disparities are and how they are connected to social determinants of health. We also need to be mindful that the solutions need to address systemic racism, particularly in San Antonio, and we use it as a case study. And we want to describe it and that the lack of health insurance among Texans is also affecting our efforts to move in this direction. And then finally, I'd like to identify concrete steps that clinicians could take to address health disparities. So what's a health disparity? Well, health disparities are often used as difference in outcomes, but it's a different health outcome that is systematic, that is avoidable, and it's unjust. And health disparities are a weaker problem because they're not simple solutions. The solutions involve structural changes. There is a large economic burden that comes with this problem, and it is interconnected with many problems in our community. Social determinants of health is an important concept that we need to keep in mind as we are trying to address health disparities. The reality is that biology, behavior, and healthcare are relatively small. They have a relatively small impact on social on the health of individuals and communities in comparison with the larger question of social determinants of health under which people are born, grow, live, work, and age, and include factors such as socioeconomic status, education, employment, social support efforts, and neighborhood characteristics. Social determinants of health, especially poverty, structural racism, and discrimination are the primary drivers of health inequities. It's important to keep in mind that this is not a uniquely American problem. Gaps and inequities are distributed worldwide, but it's important that we also learn what other people have learned and implemented.
Dr. Hyan, I am so sorry. Apparently, Crowdcast is the issue, and people are still having a problem, and we are not able to troubleshoot it. I'm going to invite the audience into Zoom, so they're going to join us in the Zoom area. I am so sorry. We've not ever had problems like this. So I'm going to post the Zoom link in Crowdcast and invite everybody in there because I want them to hear Paul's talks. So just give me a minute to get that posted. If I can find it, there it is.
I'm just going to resume for what I know.
Okay.
So I see it on podcast.
Everybody, please mute yourselves. Okay, go ahead and resume, and people can join us as they're able.
So as I was saying, social determinants of health are conditions under which people are born, grow, live, work, and age, and include factors such as socioeconomic status, education, employment, and social support. I would like to just point out to the fact that this is not a unique problem to the US. Others around the country and the WHO have had significant efforts and guidance related to how do we go about addressing these issues. And they are issues related to social justice, empowerment, material and psychosocial and political improvement, improving the conditions of people are born, shape the distribution of more money and resources. Interesting presentation. This guidance gives an opportunity for us to broaden this scope beyond healthcare in terms of how to address all disparities and giving every child the best starting place. Now, we'll take San Antonio is doing well in terms of pre-K and say, enabling our children, young people, and adults to maximize their capabilities and have control over their lives, creating a fair employment, good work for all, ensure healthy standard of living for all, create and develop healthy and sustainable places and communities, and strengthen the role and impact of health prevention. So these are aspirational goals, but these are also important components to keep in mind as we go forward. So let's talk now about San Antonio housing equity. And let's talk about specifically about structural racism, poverty, and disease. During the Depression era, there were efforts to bring help directly related to how loans were made for the acquisition of housing and other components. And part of what happened is that the San Antonio was had lines drawn around neighborhoods related to best, still desirable, definitely declining passive rich components. And as you can see from this map, these are red areas that where the banks were not willing or able to provide loans, and they were thought to be too risky, and in the process really condemned the neighborhoods and the people who live there to the inability to accumulate wealth in the context of their housing and other components. And this type of racism was actually structural, related to even the specifics of how specific neighborhoods were not allowed to make loans to either African Americans or Latinos. It's then not surprising that the distribution of the population below the poverty level really resembles those red line maps to this day in a very powerful and moving way. And if we look at life expectancy by zip code, we can also draw very similar lines, and we can see that this the age difference in terms of early mortality is significantly higher here, where it's almost 20 years higher than in areas in the surrounding area. Mortality significantly higher here, where it's almost. And in some ways, and if we look at diabetes prevalence, the same situation is understood. So we have legacy of
lots of things. Here, yeah, I think you're earlier if you need help calibrate or anything like that. You know, you can check to make sure that the baby is not running. I said,
and this systemic racism will continue to operate in San Antonio. So let's talk about the situation with the uninsured in Texas. Texas has a rare distinction to be a number one with health insurance population. Refuses to spend money under the Affordable Care Act, a decision that affects its proportion of Blacks. 60% earn too much to qualify for Medicaid and too little to qualify for tax credits compared to 9% of non-Hispanic whites. Estimates of the Kaiser Family Foundation show that 29% of the non-elderly uninsured in Texas are Hispanic, 60% of Black, and 30% of whites. Most uninsured families in Texas have at least one member working full-time or part-time. This situation has been worsened with the job losses related to the current economic crisis that have affected disproportionately those who have the lowest level of income and are experiencing the highest levels of economic strength. The Kaiser Family Foundation projects that 1.6 million Texans have already lost insurance along with their jobs and estimates that the number of uninsured Texans falling into Medicaid expansion become gap will surge past 2 million by January 2021. As we address social determinants of health, it's really important to keep in mind, now speaking as a clinician and as someone who is involved in healthcare, that the whole notion of that addressing social determinants of health is also a moral imperative. In a recent JAMA viewpoint, Don Berwick, who was the director of CMS, Central Medicaid Services, challenges the transition to the moral determinants of health. From his perspective, when fabric communities upon which health depends is torn, healers are called standard. So what role and responsibility, if any, do we as physicians have when confronted with this local reality? How can we address these issues if we are barely surviving under the weight of the pandemic? What is our professional duty in this context? How can we influence the creation of health systems that better respond to this healing imperative? Any effort to address health disparities must also challenge us to question the current structures of health systems where we work and live. So what are some concrete actions that we can take? Well, we can support policies that increase health insurance coverage protections, like the ones that are being supported by those participating in the efforts for this conference. We can support value-based approaches that deliver quality healthcare in the context of longitudinal relationship with patients. We need to support innovative payment models to support primary care, not just urgent care or emergency care. We need to build primary care systems with a best primary care team that includes integrated behavioral health. These things can be virtual or present in clinic. We need to partner with local community organizations to link patients with resources to address social needs. You and your clinic staff do not need to provide the services for your patients need that you can provide. I think it's important that as we are addressing health disparities in the context of clinical care, that we don't limit ourselves to screening, but we really, just like we wouldn't just screen someone for breast cancer and say, well, you have breast cancer, talk with that. We need to take action. So what action can we take if we screen someone for insecurity or housing insecurity? How can you link? How can we link the resources that may be available to the community? We need to recognize that patients live in a context that may have support for our conditions and changes. We need to hear the personal stories to better understand where they live. Just increase the insulin for a diabetic without understanding the chronic situation in terms of physical activity opportunities or food insecurity doesn't make any sense if you ignore the social determinants of health. And we also need to support organizations that are directly addressing these disparities. For example, the Health Collaborative is one of the sponsors of this conference of the San Antonio. And as outlined in the Health Collaborative report of 2018, income poverty, education and literacy, housing stability and homelessness, mobility and transportation, crime and violence have direct effects on health. And look at the recommendations and see how they resonate with values and preferences and support that we stay true. So I just want to encourage you to act now. Our broken healthcare system needs to reclaim the mission of compassionate response to suffering ahead of profit to effectively attend to the needs of our communities. We need to help transform our healthcare system into places where accountability is ahead of accounting and resources are allocated to optimize personal and patient health. We have a professional responsibility to address the root causes of health disparities, to embrace efforts in all fronts to practice deliberate ways that address these disparities. Thank you again for the organizers of the meeting, the opportunity to present today.
Okay, thank you, Dr. Hyan. I'd like to share my screen now and introduce our next speaker. Okay, Dr. Hyan, if you could stop sharing your screen.
Yeah.
No problem. Good. I'll share my screen. Okay. Computer's a bit slow. I want to thank the audience for your patience with these tech challenges. I'd like to thank you, Dr. Han, for your excellent presentation. I'd like to remind our audience that we have an online survey. Each of our registrants will receive an email with a survey link. You need to complete that survey for CE or CME credits, and there's a drawing for a $100 Amazon card. So it's my pleasure now to introduce Dr. Linda Solis. She held a former faculty position, with the UT Health Long School of Medicine in the Office for Student Diversity and Professional Development. She completed her doctoral program in leadership studies at Our Lady of the University and currently serves as assistant professor of applied humanities at the University of the Incarnate Word School of Osteopathic Medicine. Her special role there is to encourage learners on their journey to become holistic, open-ended, and compassionate healthcare providers. So it's my pleasure to introduce Dr. Linda Solis. I'm going to stop sharing the screen. Dr. Solis, you may begin. Thank you so much.
Thank you, Dr. Irby. I appreciate that kind introduction. So I'm going to talk a little bit today about some of the health disparities in the U.S. How did we get to where we are now? And then I'd like to share just a little bit what we're doing at UIW to prepare physicians to become culturally aware, to be aware of health disparities and other issues that really are health plagues here in the United States. And my presentation dovetails really nicely with Dr. Hyan as far as what are we doing to attack this problem, because it is an insidious problem with no answers. So first of all, one of the we came to where we are as far as these health disparities through many ways. Dr. Hyan mentioned red meat. There were also disparities in, like federal housing authorities after World War II and things like that. All of these things work together to sort of systemically build in racism and to build in these disparities of health. So part of that was the United States, the movement of enslaved people throughout the first part of our history. White owners assumed that enslaved people actually this market only for enslavement, and bodies were possessions, and so there was all kinds of experimentation going on as far as of the time, using black humans to experiment as though they were black animals. So because of this, enslaved people learned how to take care of themselves even when they had to hate. A lot, of course, was rooted in African traditions that the first generation of slaves that enslaved people brought with them. the United States. And then it led in the enslaved finding people who were natural physicians or healers and could use what they had to hand, herbs, all those sorts of things. So there was this lack of care from the slave owners that is said to be one of the core causes of the distrust that people of color have regarding health care. There's social reasons why people of color don't approach the healthcare system in the same manner that white people, the majority do. So it's really important that we actively seek out people of color who are interested in a career in medicine and bring them into our system so that they can serve alongside and help the marginalized people get the care that they need. So we have a racist history. Once slavery ended, racism did not end. Once the 1960s rolled around, racism did not end through those civil issues. We've made huge strides, but it has not ended. Racist history too, this always never fails to shock me. Nazi Germany studied American race laws that were created and enacted in the 19th and 20th century, and they based a lot of their Jewish and anti-other laws on the American race laws. And then ultimately, the Nazis decided that our race laws, the one rule that was in place, decided that those race laws were too draconian for Nazi Germany. So that's how Nazi Germany decided that instead of one drop of blood making a person Jewish, it was one grandparent made them Jewish, and then people to be deported and misused and maltreated. So there's also a maltreatment of indigenous people, of course, that happened. There was a massacre by white settlers as white people came into the lands. There was forced removal from tribal lands by the white government, white settlers. There was fear of reprisals by indigenous people because of massacres and the forced removals. So indigenous people were in a place to be mistreated and have inequitable actions taken against them. Again, at the hands of settlers coming into this country. And so distrust of white people in healthcare and otherwise, as Americans, we shouldn't be surprised at that. We have this history of using race as weapons, right? So Tuskegee, Henrietta Lacks, and beyond. Tuskegee, syphilis trials, Henrietta Lacks, these are the things that like most people, even lay people who aren't in healthcare, know about these things, and it goes far beyond that. There is still 20th and 21st century maltreatment of people of color by the healthcare industry and by the government. There are radiation studies that were going on in the early 2000s. Research on prisoners, the prisons are primarily filled with a majority of Black prisoners, people of color. There are drug studies going on that disproportionately negatively impacts Black communities. Water studies we've seen in Michigan, there are water issues, ignoring informed consent. So all of these are going on even now in the healthcare industry. And I think industry, at Dr. Hines' point, I hate that healthcare is more about business than it is about compassion and about care. But it's no surprise that we are where we are as far as people of color trusting the healthcare industry. If you want to learn more about that, of course, there's all sorts of texts and tomes and scholarly works out there, but one very accessible and excellent book is called Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present by Harriet Washington. And Harriet Washington is a healthcare journalist and has worked for some of these New York Times, Washington Post, and things like that. So that book was published in 2012, but certainly it's still historically relevant and accurate today, so I recommend you read that. So, what are we doing about this? We being medical education. I can speak to, of course, my own institution, University of the Incarnate Word School of Osteopathic Medicine. We brought in our first class in 2017, a DO student, and so we're excited that our first class of DO students will be graduating in the spring of 2021. We are hoping beyond hope that we can get past the COVID um, thing and be able to celebrate with them face to face and in person. So we are working through building in what we call physician personhood, building social and racial justice awareness into the medical school curriculum at UIW SOM. So at UIW SOM, personhood is becoming this transformation from student to physician, human being to physician, isn't left to chance. We very we have built it into our curriculum. We have what we call the P2 curricular thread, and we basically on that thread team, we focus on what characteristics should a UIW SOM DO physician have. So we want them to be empathetic, socially aware, both cultural and intellectually humble, highly reflective, and highly emotional intelligent, even under stress when they're exhausted, when they're overwhelmed. So how do we get there? Well, we use a combination of what I think of as sort of traditional medical humanities, using the arts, using text, and using self-reflection to get at things like compassion and empathy. So we do a lot of that, but we also use applied humanities. So that's where I come in. So the stuff that I teach about and talk about and research on are things like emotional intelligence, personal values, unconscious bias and micro-messaging, how our cultural identities impact how we see the world. I talk a lot about cultural humility. We can't know everything about every culture that isn't ours. So what we can do is remain open-minded and humble and willing to learn from people of cultures that differ from ours. I also talk about the importance of crucial conversations. How do we have conversations across differences so that we can ensure that we're getting what our patients need, that we're hearing what our patients are trying to say to us? So I talk about the history of medicine in the U.S. I focus on the history of health disparities in the United States, as we talked about earlier today. All of these things, of course, lead to systemic racism and bigotry. And so our learners, DO students, all physicians and medical students need to be aware of these things and why how some of these health disparities were created. And then we also embed our learners from day one, like literally during their week of their welcome week, their orientation week. They're out in the community, or before times, not COVID times, they're out in our community around Brooks Air Force Base where we are located. But they're out in the community, engaging in the schools and they work with Patients for Hope. They work with the housing authority. They work with municipal government. So we embed our learners from day one of their medical experience into the fabric of the South Side. They go out and visit people in their homes on the South Side and the Southeast Side so that they can get to know people literally in their community where they live. And this is an important part. A lot of our medical students come from privilege, whether it is skin color privilege or whether it's just a privilege of socioeconomic status and wealth. And sometimes they haven't had the opportunity to engage with people who were raised very differently than them. And so we help them do that by by asking our community around Brooks Air Force Base and the UIW to open their doors to our learners. And we have had a fantastic response both from learners and from our community. So physician personhood, or P2, is also built into and throughout our curriculum. So we use small interactive group sessions so our learners come together groups of 8 or 9 with a physician facilitator to work through cases. And these cases are very much, a physician personhood is very much built into these cases, whether it is a person who doesn't have health insurance, someone who has poor enough health insurance that they haven't come to the doctor even though they're having symptoms, things like that. So we build these sorts of things into those small group cases. We also touch on physician personhood and health disparities in large group sessions around things, as Dr. Hyan mentioned, around things like diabetes, around things like the LGBTQ community and their high risk areas. We also talk in our module that is on sexual health, talk about African American women, despite their socioeconomic status, having worse outcomes when it comes to maternity and giving birth. So we talk about these in large group sessions when the entire class is together. We talk about it in docs. Docs is what we call our clinical skills area, developing osteopathic clinical skills. That's where that important communication stuff comes in. How do I talk to someone whose background is completely different than mine? How do I work with a patient who says, you know, I know that my sugars are high, so I've been using this home remedy, this traditional remedy to help myself, and I want to keep doing that. How do we work with a patient like that to help them feel heard and understood and still receiving the health care that they need? We even talk about it in structures. Structures is what we call our anatomy lab. We even build social determinants of health and those types of things, physician personhood, into our structures, our anatomy program. And of course, I've touched on the community engagement program. We also, within community engagement, do have our students, our learners, do research on health disparities and on things like physician professionalism and what professionalism means in light of this P2 curriculum that we're building in. And then, of course, in the clinical rotations, that's the 3rd year, and some of the 4th year is spent in clinical rotations. And the clinical rotations, again, are in often community clinics, community hospitals, where people of lower SES are seeking health care. We also have clinical rotations taking place in Laredo and other cities that we know have these social determinants of health and health inequities really impacting the lives of the people that live there. So, so all of this throughout the 4 years of the medical school curriculum, our learners hear over and over about what are social determinants of health, what are health disparities, what are health inequities, how did we get here, what can we do? Again, to Dr. Hyan's point, what can we do to make sure that we are working against those health disparities and hoping to heal them? And one of the things that I talk to my learners about a lot is just the fact that race itself is not a social determinant of health. Racism is, and we can replace race with any of those isms, right? Like racism is a social determinant of health. Bigotry is a social determinant of health. So it's not the person's skin color or socioeconomic status or sexual orientation that determines a person's health outcomes. It is the systemic racism and bigotry, as Dr. Hyan stated, that is a social determinant of health. And so I will leave you now with this word cloud. And this word cloud is how we define physician personhood. So you can see all kinds of stuff in there that I didn't even remotely have an opportunity to touch on, because again, this is a 4-year threaded curriculum throughout all 4 years of medical school. So we talk about social intelligence, we talk about critical thinking skills, we talk about professionalism, we talk about implicit bias, we talk about the history of healthcare, we talk about cultural humility, self-reflection. All of these things come together to hopefully help our learners sort of embed these ideas of physician personhood that they'll hold on to throughout their third and fourth years of their clinical rotations, and then on into their residency and beyond that when they become a fully fledged attending physician. So those are some of the things that we're doing at UIW SOM to address these social determinants of health right here in San Antonio, and eventually throughout the nation as our brand new physicians go out into practice. If you have any questions or want further information, you certainly can contact me, and the organizers have that contact information. So thank you, Dr. Irby, Dr. Hyen, for your remarks, and I will stop sharing, and Dr. Hyen, I will turn it back over to you.
Dr. Irby?
Yes, okay, I was just waiting to be unmuted, sorry. Okay, hold on one second. Okay, I will share the screen now and introduce our next speaker. Can y'all hear me? Okay, good. So I'd like to thank the audience again and remind everybody to please complete the survey. A link will be emailed to all of our registrants. The survey is important to obtain CE and CME credits, as well as win a chance for an Amazon gift card. So it's my pleasure to introduce our next distinguished speaker. Dr. Sandra Guerra is an executive preventive medicine physician. She's a former regional medical director at the Texas Department of State Health. She's also the former preventive medicine residency program director, which implemented an innovative multi-location graduate medical education experience. She's a former vice president, chief medical officer for TRICARE through the Humana Military, and one of the nation's largest accountable care organization plans with 6 million insured military family lives. Currently, Dr. Guerra serves as interim deputy director for our own San Antonio Metropolitan Health District. Dr. Guerra, go ahead and...
Thank you, Dr. Irby. Are you able to hear me okay?
Yes, yes, we can hear you.
Great. Well, hello, everyone. Thank you very much for the introduction. My name is Dr. Sandra Guerra, as Dr. Irby said, and my presentation is going to be a little bit different than these wonderful previous speakers that we've had, in that I am going to talk to you a little bit about what our experience has been in San Antonio regarding COVID response. It has been an amazing time. I can say that I joined the San Antonio Metropolitan Health District again just a few months ago, starting in July. So a lot of work had been done by an amazing organization of the local health department here in San Antonio, one of the largest cities in the country, trying to respond to this unbelievable threat that we have had in our community and across the world. So some things I want to start off with is listing those additional stressors. We all recognize and understand that COVID in and of itself is a threat to our population, regardless of race and racism and all the other things we see going on. But let me add a few layers of complexity for this wicked problem that Dr. Hyen definitely expressed. So in the midst of a pandemic, there are some things that we can usually expect. During a pandemic, there is disruption to normal ways of life. During a pandemic, we have to evolve and change in the way we approach things, including our belief system, our morals, and our values. That is not unique to this particular pandemic that we have been experiencing. But nonetheless, here are some things that have really caused another layer of challenges when we are responding to a pandemic. First off, as all of you may recognize, there has been civil disruption. That is not unique and different to this pandemic, but the way it has manifested itself has been something that has been different. We have seen in previous pandemics civil disruption happen because we are at war with another part of the earth. There are times that we have had civil disruption because of mass migration that has occurred. We have seen during previous pandemics civil disruption usually tends to occur. This one in our country, at least so far in our pandemic, has really been about a reduction in the tolerance that populations have to a certain type of mistreatment. And in this one, of course, I'm talking about protests that have occurred that do have race and our own way of approaching how people are treated during a encounter with the police that definitely has come to the surface and provided quite a bit of complexity in being able to respond to a pandemic. We also see that there's other stressors that are normal. How do we deal with holidays? Holidays has been something that as a country we have normally participated in certain ways. Well, a pandemic really does impact traditions, cultures, ability to exercise those freedoms and those liberties that we normally take for granted when we are not in a pandemic. What we have seen in our environment, in our community, has been surges that follow a holiday because of people's need to gather and to express and to celebrate. We have seen some challenges when it comes to how that impacts the transmission of this virus. We also have seen things that have impacted people's health other than COVID really starting to do a scary climb because we have suspended either preventive or elective or routine health care during a pandemic. This has downstream impacts to the overall health of a population, especially those populations that tend to have a limited access to health care. So when we think about screening services, immunizations, routine care for diabetes or hypertension, and then you layer on top of that an exposure to COVID, we definitely have some challenges when it comes to how we're going to deal with this in the long term. We also have seen that San Antonio is not immune to other impacts to our community, such as being a home for people that need sheltering during a natural disaster. We have seen hurricanes impacting our Gulf Coast and even other states where San Antonio has historically been a safe space for persons who are evacuating from a disastered community to come to. That causes additional mixing of populations that don't normally interact with each other. And when we are dealing with a pandemic and a communicable disease, that definitely has an impact. We've also seen disruptions in our family cultural separations that is not the routine for us. So whether that means we're separated from family more permanently that we normally travel to visit to, we are also separated even within our own community from parents and grandparents and aunts and uncles and loved ones that our community really has always embraced as one of the cornerstones to our cultural and our way of life. So that has definitely impacted and put an additional stressor in responding to this pandemic. I don't think I'll be surprising anyone by saying there has also been a political divide. Taking the response to a communicable disease and taking it to the political stage has been something that is not unique to this pandemic, but it's definitely something that has not been a lesson learned from previous pandemics where we don't try to politicize a healthcare response. That has been something that is definitely there and continues to be a challenge that we must carefully overcome, especially when our primary mode of response is through governmental entities. We have to be very mindful of the fact that a political environment really surrounds the response. We also have seen the division of financial resources being something that is very impactful in the area of COVID, and I'm going to get into that a little bit more. It's not just healthcare and access to healthcare that has been an issue. It is really about your ability to pay rent, your mortgage, be able to go to work and be able to choose to not go to work if you find that it is a threat to your health or the health and well-being of your family. These are all aspects of a responding to a pandemic in a respiratory borne type of spread that makes it a challenge. We have seen educational disruption happen. And when we recognize that in San Antonio, for a vast majority of the populations that we're discussing, these minority populations that we are all a part of, we recognize that education is a pathway to be able to gain further advancement in our society. So, disrupting that educational environment is definitely something that has been impacting our COVID response. Everything from asking for persons to learn from home to not be able to go to a school environment. And we all know the reality of food insecurity and other social determinants of health that are tied into that educational environment. And then the final one that I will add that is a stressor that's a little bit more invisible to everyone, but it's one that we recognize, and I'll talk about here more in a second, and that is the corporate aspect of healthcare. And so I know that's probably taking folks a little bit by surprise. But when we talk about wanting to advise any sort of health industry within San Antonio, what they should be doing regarding PPE or testing or isolation or staffing, the amazing response that we get is we want to do that, but we need to speak to those corporate heads. The corporate heads are often not in our community. They are dispersed throughout the United States, and yet they have a decision making impact into what happens at a local level, which has been something that I believe in previous pandemics we didn't have as much of. So this kind of nationalist approach to localized healthcare is something that really has been impactful. So even though we may have local leadership and local desire to do the right thing, they are very much tied to that. The microcosms that I have been working on for the San Antonio Health Department, I think that we can speak to will sort of highlight some of these stressors that I have just described in my beginning of my presentation here. These microcosms or special populations are really around the area of congregate settings. And often there is a lot of discussion around what does a congregate setting mean? Well, it usually means it's an environment where people are gathered and don't often have the choice to not be there. Some of that is a little bit different, but for the most part, it is a gathering of people. So when we think about long term care facilities, such as skilled nursing facilities, assisted living facilities, we think about um, school environments like universities and dormitories. We think about shelters such as those that provide services to persons who are normally without a home or homeless populations, foster children, immigration detention, rehabilitation, and then, of course, we talk about correctional facilities. Those are kind of some of the big buckets I want to touch on. What we see in all of these is that those disparities that we have talked about already by our distinguished speakers are just almost magnified on a very large scale when we start talking about congregate settings. What we see there is that the ability to respond at the level that they need to protect those that they're responsible for against COVID is a challenge. And let me talk about some of those very concretely. So, when we talk about long term care facilities, nursing homes, and others, we see a disproportionate amount of not only Black and Latin populations in these facilities for a variety of reasons of what led them there. Everything from a disproportionate impact of their health decompensating earlier on and causing them to have to be in a facility, the inability of families to be able to provide long term care in their own home for these families. And so there's a lot of social determinants that drove a resident to be in a long term care facility. And then when the pandemic hit, what we saw across the country was something that we saw here too, that the spread of a respiratory virus within that environment is something that happened very quickly. And these are very vulnerable populations that when they were impacted by COVID, a disproportionate ultimate death that came from being exposed to this virus. So, when we think about a skilled nursing facility, this is definitely a microcosm of the rest of our community. We have disproportionate number of minorities that live there, a disproportionate number of minorities who work there. We have the very vulnerable population because of long-term history of diabetes or Alzheimer's or other things that impacted their inability to live on their own at the end or the later years of their life. And then we lay in one other complexity, if that's not bad enough, and that is dialysis persons. So people who require dialysis but live in a long-term care facility go in and out of the facility regularly, and they are being exposed to the virus at a higher rate than all the rest of the residents. So, what we've learned about long term care facilities that you probably haven't heard a lot about in the media has been that they have very limited resources to be able to respond to a pandemic and a respiratory illness. They all vary in their abilities to actually wear PPE, access to PPE, access to testing. There are so many different things that long-term care facilities are impacted by. So that is a great microcosm. When we look at shelters, the same thing, inability to have access to testing, to ability to quarantine, to isolate, to use PPE, everything from masks to gowns to face shields. These are all things that they don't really have a lot of experience with, and having to get them up to speed to be able to protect a congregate setting has definitely been a challenge. Correctional facilities already were disproportionately impacted by having a more Black and Hispanic populations in there. And so now they also have those underlying health conditions, and they have the inability to leave and be able to protect themselves from the virus. These are all things that have had a significant impact. I'm going to transition a little bit to what comes next because I know I've been talking a lot about the challenges that we have had. So, just at a high level, here are some things that we as a community need to be aware of when it comes to the impact of this virus. One is that we're going to see a um, prioritization of who gets a COVID vaccine when it becomes available. This will be a challenge when we try and look at how the impact of racism, how the impact comes to who is prioritized. And I know no one wants to use the word, but there will not be enough vaccine for everyone. So, in and of itself, that's called rationing of healthcare. And we will have to be very deliberate in our view of how our policies impact those persons that normally are disenfranchised from healthcare. We have to be ready for the next surge because we are seeing it across the world and across the country and across the state. Another surge is almost inevitable, and we have to be ready for what that means for our community. We realize that there may be more civil disruption that may occur. We have a massive election that is looming on us, and the outcomes of that may cause more impact to our environment. We are seeing an erosion of trust in the public health systems for a variety of reasons, and we must need to deliberately try and rebuild that trust. We recognize that those trusted sources of information for our minority populations has definitely gone away. We think about church, we think about doctors, we think about school environments as trusted sources, and those have been minimized. We recognize our economy is going to be impacted by this going forward, and we have to be prepared for what that means for our populations. And then finally, we have to recognize that the long-term sequela of this virus may disproportionately impact our populations that we're talking about today because of either long-term effects, the suspension of preventive services, and the ability to regain trust in our healthcare community. So those are some of the things I wanted to make sure we talked about today. I look forward to your questions. Thank you very much.
Okay, thank you, Dr. Guerra. Wonderful presentation. I'm going to go ahead and share my screen, and it's my pleasure to introduce our final speaker for this morning. Just need a second for the slide to come up. So Dr. Rogelio Sainz joins us this morning. Dr. Sainz is professor of demography at the University of Texas here in San Antonio. He received his bachelor's degree in social work from Pan American University, his Master of Science and PhD in sociology from Iowa State University. Dr. Sainz has written extensively in the areas of demography, Latino-Latina issues, race and ethnic relations, inequality, immigration, public policy, social justice, and human rights. It's an honor to present to you Dr. Sainz. Dr. Sainz, go ahead, sir.
Let me see. Somehow the slide isn't coming in. Let me, let me see. Sorry, the presentation isn't showing up in the screen here. I'm sorry. Oh, here it is. Sorry about that. So today I'm going to be talking about the disproportionate impact of COVID-19 on the Latino population. And what I've been doing is work related to kind of looking at the national pattern and what has been going on, and as well as here in Texas as well. And then initially I put together data
based upon the COVID-19 data portals, have been writing a monthly blog for Latino Decisions, in which I'm providing an overview of the trends that are taking place. The theoretical grounding, I won't repeat, but Dr. Hayen put it very, very well in terms of the systemic racism, and we find that systemic racism is really the culprit here, and the many whites, as well as people even in our own community, have been in denial for a long time regarding systemic racism and white supremacy. But we've seen that the pandemic and the murder of George Floyd and other people of color have made it difficult to really deny the deep systemic racism that is taking place here. And we see the confluence of racial inequities. We see the significantly higher infection and death rates from COVID-19 in communities of color compared to whites. The essential workers on the front lines in essential industries that we find in our Latino community and African American community, the loss of jobs and the lack of job recovery, the lack of medical insurance, particularly in the Latino community, where about 30% here in Texas of the persons 19 to 64 do not have health care insurance. We see it in the crowded living conditions and multi-generational households, as well as the unauthorized immigrants that have been left to fend for themselves, being denied of the $1,200 check that was distributed some time ago. And even for those who are US citizens, but they're married to unauthorized immigrants. These inequities did not just crop up during the pandemic, but reflect centuries and generations of neglect of people of color. Sociologist Sabrina Strings, who is at the University of California at Irvine, just recently, about 2-3 months ago, wrote a piece in the New York Times where she illustrates with the concept of bare necessities for Blacks and other people of color that transcend back to slavery, in which there was so little investment in people of color. And we see it, my good friend and colleague Juan Flores from San Antonio always talks about the minimalist approach that Texas uses in terms of its public policy related to investment in its people of color here. The data source that I've been using have been the COVID racial data tracker, as well as the CDC health disparities, race and Hispanic origin, the provisional death counts. There are some methodological issues having to do with the data are provisional, they're always changing. There's a comparison issues in a number of states. The old question, how do you compare, for example, Latinos who identify as whites from the white population? And there's still probably about a third of the states that do not distinguish the two. So it's difficult to compare whites and Latinos. There continues to be the lack of gender breakdown. And then states vary tremendously in terms of the processing of cases and death, particularly here Texas has lagged significantly behind. And then it's limited in terms of the data analysis that we can do. What I want to do is share some of the ongoing results that I've observed. Early on in May, we found that almost all states across the nation, Latinos were disproportionately overrepresented among people that were catching the virus. And that continues to be the case. The only state right now that has been slightly underrepresented relative to their proportion in the overall population is the state of New Mexico. But for the most part, that state is going to join all the others in terms of being disproportionately overrepresented. And then when it comes to being overrepresented among states with deaths due to COVID, initially there was only one state, and that was New York, that at the time presented data aside from New York City. We've seen the growing numbers, but still they don't match the contraction rate. As a point of information here, Texas continues to be the only state where Latinos account for over 50% of people who have died from COVID-19. So here in Texas, we have been particularly devastated. But one of the reasons why we find that Latinos, if you look at the statistics that I just presented, that we're overwhelmingly overrepresented among people who catch the coronavirus, but at the same time, probably about 20 states that we're overrepresented among people who are dying. This distinction has to do with our age structure, that Latinos, we're a very young population. So that if you look on the graph here on the left-hand side, the table, it shows that Latinos, close to a third of us are less than 18 years of age, versus 19% for the white population. And with the elderly population, 65 and older, we're 1 out of every 14 in the Latino community compared to 1 out of every 5 in the white population. So really, whites are disproportionately overrepresented in people who are more likely to die from the coronavirus. And then once we take age into account and we compute age-adjusted COVID-19 death rates, you can really see the true picture that takes place. And we find here that compared to the white population, African Americans are dying at a rate that is 3.4 times higher than whites. Latinos are dying at a rate that is 3.1 times higher than whites. Native Americans about 2.5 times higher. And even the Asian population that has higher socioeconomic status, higher levels of education and income compared to the white population, they are still dying at a rate that is 45% higher than the white population. And we can see the distinctions also in the demography of who is dying. In the case of the white population, about 90% of people, whites who have died, are persons 65 and older, compared to 63% in the Latino community. In the Latino community, more than 1/4 of people in our community who have died are people 50 to 64 years of age, compared to only 1 out of 11 people in the white population. And then if you look at under 50, 1 out of every 9 in the Latino population has died from COVID, compared to less than 1 out of 50 in the white population. So you can really see the risk factors that are taking place here. And that has to do with people who are out in the front line that we find in our Latino community, African American community. And you can see these are age-specific death rates from COVID. And you can find that if you look at all the way from age 5, all the way to 64 or so, Latinos are dying anywhere from 6 to 9, 10 times higher rates than the white population. And even among children, that we still don't talk very much because the numbers still, fortunately, are low, but there are unfortunately deaths that are taking place, and they're more likely to be taking place in the Latino community. Latino children dying at a rate that is about 3 times higher than the rate of white children. And if we look at nationwide, the children less than 18 years of age that have died, 84% are non-whites, people of color, and 47% are Latino children. These are children, as schools opened up and so forth, that our own particular children in our communities are much more at risk of the white population. And then I'm going to touch briefly on an article that was just published, that I published with the co-author Mark Garcia at the University of Nebraska-Lincoln. And this is a disproportionate impact of COVID-19 on older Latino mortality, and what we subtitled the rapidly diminishing Latino paradox. And this is a paradox that shows that for the last 3 decades, Latinos, despite having lower levels of education, higher levels of poverty, more lack of insurance and so forth, that we tend to have lower mortality rates and live longer than the white population's a paradox. And we've seen here, these are data at the top section here, looks at COVID deaths, and we find these are 55 to 64 and older, and we find that Latinos are dying at a rate that is much higher than the white population. If you look at the residual deaths, that is, deaths that are not due to COVID, but to all other causes of death, the paradox is in place there. Latinos are dying at a rate that is lower than the white population, just as has been the case the last 3 decades. But then if you look at the overall causes of death, we find that the paradox has already disappeared in the 65 to 74 age category, where we find 3% higher death rates compared to the white population. And that paradox is fast disappearing also for the 55 to 64 and the 75 to 84, where it seems to be just a matter of time that we're going to lose that paradox. And this graph shows you the 4 age categories, and it shows that for each of these are data from 1999 all the way to 2018, we find that Latinos were dying at a rate that was about 20% less than whites consistently throughout that almost 2 decades of data. But now COVID, and you can see the blip up that is taking place. We've already seen the loss of the paradox at the 65 to 74, and then that we're going to rapidly see that at the 55 to 64 and 75 to 84, and possibly the 85 and older. And in concluding, we find here that people of color, particularly Latinos and African Americans, have been impacted terribly by the pandemic. It is not a major surprise given the systemic racism that we've covered here in this particular panel. It is the cruelty and the indifference from leaders, from the president on down to the governor of our state, that has failed to protect people in our community. It has been the dawning of a mask, for example, that has become a political issue. And it has been the urgency to open up states for business and opening up schools for people getting reelected and so forth. And it is people of color that are increasingly being put in harm's way as fodder for capitalism, as well as for the reelection of politicians. And unfortunately, as long as it is people of color, Latinos and African Americans in particular, but Native Americans as well, that are the ones that are disproportionately dying, there is no political urgency to control the spread of the pandemic, to impose laws regarding the wearing of masks in public, or to provide the safety net that is needed for people to cope with the devastation. And we're running out of time, so I'll conclude with that, and be glad to answer any questions or any information that you might seek from me there's my email address. Thank you.
Thank you, Dr. Saenz, very much for that very insightful presentation. We're running a little bit short on time, but we do have a question that I'd like to pose to our panel from the audience. This is from Luz Rivera. Her question is, during listening sessions with LGBTQ plus individuals, some of them indicated experience feeling that some primary doctors seemed uncomfortable addressing sexuality issues or recommending post-exposure prophylaxis. How can this be addressed using Dr. Hayan's Act Now and Dr. Solis's physician personhood concept? How can we help our medical providers and allied health workers to see themselves in the HIV space? So anyone that can answer the question is.
I'm glad to take the first step and then would defer to Dr. Solis. I mean, I can tell you concretely, we have a residency in family medicine that is located in the zip code that has the earliest mortality in San Antonio, the one that I pointed out in the maps. And we have 45 residents who are training as family doctors, and they have organized and they are working in pride clinics. They have a specific curriculum related to the needs of the LGBTQ communities, and it's something that is discussed directly and addressed in a very sort of positive and without any holding anything back related to the needs. But our residents are illuminated, and our faculty respond to that in a way that is very positive. And the School of Medicine itself has a pride clinic that is free for the community, and their students from first years all the way to fourth years are involved in making that happen. It's not enough, but it's a beginning.
Absolutely, Dr. Hayan, thank you. So I, full disclosure, I was working in undergraduate medical education over at UT Health Long School of Medicine for years, and I was the director for diversity, equity, and inclusion there. And so I'm very familiar with the Pride Clinic that Dr. Hyan mentioned that their students work through, and they have been really, UT Health has really been sort of a goal for me, the way they teach about LGBTQ health. And so what we're doing is we are introducing it. We do introduce LGBTQ health and related issues into the curriculum. And I work very hard not to just talk about LGBTQ plus health in the infectious diseases module, because that's where it tends to fall because of HIV/AIDS. So I talk generally about power and why people might not feel empowered to talk to their physician. And so one of the examples that I use is the LGBTQ plus community may not feel comfortable talking about their sexuality, even to their physician, and what as a physician can be done about that. So opening up those lines of communication, building that sort of safe space within the clinic. We even talk about, like, if you're going to create your own clinic, what does your clinic look like? Are all of the pictures on the walls of cisgender straight couples? Or do you also have pictures, an art representative of LGBTQ plus couples and things like that? So we also talk about the intake form. Like, does your intake form only list male and female? Or does it also list male, female, and then a write-in opportunity, right? So we talk about these, not just like the more like esoteric sorts of theoretical things, but we also talk about what can be done just on a super practical level to help all patients feel heard and included in the clinic and in healthcare. I also host, and this was an idea that I stole right from my work at UT Health Science Center, the School of Medicine. I host a transgender health panel, and so I have people who identify as transgender come in and talk about not the politics of it at all, but just what is it like to be a person seeking healthcare while being also identifying as transgender. And so those folks, when they come into our classroom, they talk about things like, you know, I go into my primary care physician, and first of all, the intake form doesn't have any place for me to write my real name. The only room that's on there is for my dead name. And then they dead name me when they call me in from the waiting room. And then, you know, and then, so all of this is on my mind, and I'm trying to deal with all of this stuff. And all I am at the doctor for is because I got a sinus infection and I need some antibiotics, right? So there's all sorts of things that are wrapped into LGBTQ healthcare, including how do we prepare physicians to be more comfortable talking about sexuality in general, talking about sexuality for the LGBTQ plus patient. How do we talk about having safe sex in a same-sex couple? How do we talk about PrEP, the prophylaxis, right? How do we talk about these things? And so we try to set up cases, we try to set up opportunities in the curriculum for our learners to think about those things in the first 2 years of the curriculum. And then they also have volunteer opportunities with UT Health's Pride Clinic and other areas in town, other clinics, et cetera, in town. So that's what we're doing on the sort of medical education side of things. And I will say too, that UT Health and UIW-Assam, we are not the only medical schools or healthcare professional schools preparing our students like this. This is becoming more and more expected in medical education and nursing education, et cetera, by students and by faculty alike. So thank you for that question.
Thank you, Dr. Han, Dr. Solis. We have a question for Dr. Guerra. The city of San Antonio has assembled a large coalition of public health organizations, health systems, and multiple service organizations to address the COVID-19 response by our city. How have mandates, policies, and directives from state government officials impacted the implementation of these initiatives and interventions? And what lessons has the city of San Antonio learned in order to advance the city's preparedness for any future health risk to our population? Big question.
Yeah, big question, and I'm not sure that I can answer all of it, but I'll definitely do my best. Bringing a coalition together and having all the different inputs has been extremely valuable for our response to COVID and, of course, any future issues that we may have. Sometimes things that are asked of that coalition are going to be very basic, and other times they're really leading how we are going to be reopening schools, how we are going to be reopening lines of business. We are looking to them to bring us not only their expertise in their field, but also representing the community. So that has been really important. How do regulations across the state impact us? Well, sometimes we're surprised. Sometimes we think we have the ability to be able to do something to protect the population and come to find out that the state disagrees with us, impacts a different type of policy, takes control over a certain area, whether it be schools or nursing homes or any other place that we see a risk environment. So it has been something that when I talked about politicizing the COVID response, it's both politicizing on the grandstand that you see on your debate screens or anything else like that. And it's also in the more subtle ways, which is people that are currently in leadership being able to decide what is the way forward versus what is the way that needs to be allowed to be I guess, adjusted at the local level. Now, that being said, for instance, in San Antonio, we came out with a mask mandate before the state did. And there were people who agreed with it and people who disagreed with it. And then ultimately, the governor followed suit and made a statewide mask mandate, which we think has really been a huge win for public health to get that in place. And we hope that that doesn't go away anytime soon. So that has been a way that local government, local relationships with coalitions, that we come up with a local policy that ends up being adopted at a state level. But often it's the other way around. We come up with something that works for us locally, but yet the state steps in and says, this isn't something that is going to be beneficial perhaps to business or isn't going to be beneficial to making sure that people get the education the way they can. They believe that it's not something that can be universally applied. So there's a lot of complexity to trying to answer that question. But one of the things we have found as something that's been extremely valuable has been the bringing in of a coalition and getting various inputs before making a policy or a mandate or a resolution within our community. And I think that will probably continue over the long term.
Thank you, Dr. Guerra. Thank you. We have a question here related to translational or applied research. So it's addressed to Dr. Science, but our other professors could certainly chime in. In academia, the terms translational or applied research have been applied to evidence-based conclusions regarding cost-effective programs, interventions, and policy changes to improve access to care and the health status of vulnerable populations. Still, when groups, community-based groups, or academicians or advocacy agencies take this information to legislative decision makers, it stops. It stops right there. Do you have any insights for any advice for community-based organizations as far as strategies to utilize evidence-based research to truly apply the findings to policymaking?
Yeah, I think that that this is the goal that we have in the social sciences, is that we want to do work that is going to have to be applicable to try to make changes to improve the conditions and so forth. and oftentimes I think they fall in deaf ears. I think one of the strategies has always been, myself as well as other scholars that have tried to be socially engaged, has been trying to get our research out there in easy to digest and circulating it in op-ed essays, policy briefs, and so forth, and trying to get that as widely distributed as possible. And I think in terms of working, I think with community organizations is another way of trying to get that information out. I've worked here in San Antonio with NALCAB, the National Association of Latino Community Asset Builders, and trying to deal with changing the conversation on Latinos. So those become very, very important. So one of the efforts that has paid off that I was involved in is I did a research project for the city of San Antonio, and it was on the status of women in San Antonio, and that really was one that has gotten a lot of traction here by City Council. One of the very disturbing trends that came out, in addition to the inequalities and so forth that women face, was the partner violence and the homicide at the hands of intimate partners and so forth. And that, to me, I did get a lot of satisfaction in terms of seeing that there were actually people, policymakers here in our own community that were listening to that and have been implementing a series of works trying to deal with the results from that study.
Thank you, Dr. Saenz. And we are running a little bit over, but I'd like to end with this last question for Dr. Han, Dr. Solis. Given the current and anticipated continuing shortage of family physicians and primary care physicians in general in our state and country, how do you see the role of advanced practice nurses, physician assistants, and clinical personnel changing to deliver truly holistic and integrated care? And also, if you could expand on the role of telemedicine as we're seeing it now. Dr. Hayan or Dr. Solis.
Well, I think that it's important to keep in mind that, let me answer the first question first. I think that one of the things that happened very quickly during the pandemic and very effectively is that both telephone consultations and video consultations were reimbursed appropriately in the context of care. And we have evidence from Texas that many primary care offices were in severe economic distress because of the changes and because people are not coming appropriately so to the clinics and lacking that. So many health systems, including ours, changed dramatically, and we now have a very large proportion of video visits. The problem with that is in our less well-resourced communities, video visits are often not available. And even if you do, you may not have the access to the Wi-Fi or other components that are necessary. So for now, there is an option of doing phone visits, but the reality is that for someone who has hypertension or diabetes, you can't really assess where they are without having an in-person visit. So I think as we transition and we have an opportunity, we need to find ways to balance those two. As to the first question, we need to have more primary care doctors. I think that whether they're coming from our sister school or from us, we need to increase the proportion of primary care doctors across the country. I think that sometimes PAs and nurse practitioners are proposed as alternative, but if you closely look at what PAs who are trained are doing, the majority are not doing primary care. They're going into specialty care. So the actual proportion of PAs who are graduating are not necessarily going into primary care. And nurse practitioners is a little more difficult to assess, but I think there's also not a preponderance of primary care. Well, that data is not clear. But I think what it is clear is that we need to be creative and innovative in terms of how we put teams together. because there are some visits and there is some care that can be given, whether by video visit or by alternative providers. Someone has a well-controlled diabetes and hypertension doesn't really need to be seen every 3 months. It is the healthcare system that is based only on fee for service, that is based on profit, that sort of demands that. So addressing issues, reinventing how primary care is delivered, and bringing teams that include not only nurse practitioners and PAs, but clinical pharmacists and behavioral health consultants and others to address the full picture. One thing that wasn't mentioned when we were talking about the Clinic is that the health information systems also need to be able to reflect and capture appropriately that information, not only for sexual orientation, but also for social determinants of health. So whether someone has food insecurity, whether someone has issues related to being in isolation or not having transportation or not having so we need to be able to capture it in a way that then others can be benefiting from that information.
Very good.
So I'll chime in. This is Dr. Solis, and I am putting on my virtual armor because the physicians in the room are going to be virtually possibly throwing rocks at my head when I say this, but I do think that one way that we can work towards solving this issue of not having enough primary care or family physicians is to focus in PA schools, focus in advanced practice nursing, have a track that they can focus on family health or being a primary care physician. And then after they successfully navigate that track, they do a residency perhaps for a couple of years in a clinic, and then they get an extra licensure that allows them to work without direct supervision from physicians. I know that is very a touchy subject with physicians. I know that, but I think sometimes we need to peel back what our reasoning is, and if I'm treading carefully. I love my physicians. I love my physicians, and none of us would be here without our loving and caring physicians. But I think that if we are letting ego stand in the way of helping patients, helping citizens find and reach optimal health, then we're doing something wrong. And this is not there is no easy fix, because our health system is, as others have alluded, and as all of you know, an utter disaster and disgrace. And so there are no easy fixes for this issue of a lack of family physicians. There's also not an easy fix of how do we, if we decide to change PA schools and nurse practitioner schools to give them this family medicine track, well, what needs to change there? What laws need to be adapted and all of that? So I think, again, as we've spoken several times throughout the morning this morning, we need to be creative, innovative, and courageous in our thinking about how to solve this this issue. So so that's my 2 cents. Thank you. I love my physician.
And we love you. And I don't want my comments to be misinterpreted. The reality is that our PAs have a very strong primary care track. They train in primary care. But the reality is, because this is a wicked problem, they don't get paid enough if they're in primary care. They then go to orthopedics and they go to other specialties. The reality is that primary care is the most difficult field of all in terms of complexity. We actually have done studies where we look at the complexity of primary care. People don't come in with a label that says, I have a heart problem. They come in with their full humanity and their full suffering, and we need to address them.
Yes.
So I have terrific partners who are PAs and nurse practitioners that work in my clinic. But I'm having a conversation with one of the PAs who's saying, gosh, I love it here, but this is so hard. I want to go to the emergency room, or I want to go I want to go and be in cardiology. So I think a part of the issue is changing the whole culture. I agree with you wholly. But I think and again, this is a wicked problem. It doesn't have simple solutions, but it's not either or, it's both and both and integrated in a way that is empowering. And part one is changed dramatically. And I think this is the way primary care gets paid. Right now we get paid to do things 2 people, now 4 people. And we need to change that so we can get paid to care 4 people. And in that context, then the whole system changes in a dramatic way. The other piece is that the percentage of healthcare expense that goes to primary care is only 6% of the entire budget. We need to change that dramatically. And in some states, they've changed it to 20%. And that makes a huge difference in terms of what we can do. And I'll be quiet now. I thank you, Dr. Solis, for getting me engaged. And I just have to recognize that we have 3 family doctors on the conference.
You got it. Okay, I'm going to share my screen now and go ahead and end this session. I want to thank our speakers. And let me just bring up the final 2 slides here. So honestly, the topic is so important and so expansive that we could have a whole day symposium or a whole week symposium. But clearly the knowledge and experience that our distinguished panel shared with all of our audience has been very, very helpful. We thank each of you very, very much. So we want to thank especially our primary sponsor, Methodist Healthcare Ministries of South Texas. Again, mention our collaborators, without whose help this would not have been possible. The Health Collaborative, National Hispanic Medical Association, San Antonio Health Literacy Initiative, and the Texas A&M Colonias program. So I'd like to end, I am so sorry. Let me go to the very last slide. I'd like to end with a quote that I think encapsulates, summarizes everything that, oops, sorry again. It summarizes everything that we have been essentially talking about, and that's doing something about with all this information. So Martin Luther King Jr. said, "Our lives begin to end the day we become silent about things that matter." So the message, I think, of this whole symposium and conference is, in our roles, in our respective roles as teachers, as students, professors, physicians, nurses, there are things that we can do specifically to move the needle, to advance, to advocate for populations that we care deeply about. So with this, I'll say goodbye to everybody and thank our panel once again. I want to thank also Nowcast for their excellent facilitation of this entire platform. So Godspeed to everybody.
Thank you.
Thank you.
Thank you.
You're
Thank
welcome.
you all.
Goodbye, everybody.
Bye. Thank you.
Bye-bye.
Bye.